All right, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is complication of pharmaceuticals every optometrist should know. It is a synchronous virtual course that I presented by my partner, Dr. Greg Caldwell, who is a graduate of the Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease at the Eye Institute in Philadelphia. He's a fellow of the American Academy of Optometry, a diplomate in the American Board of Optometry, a member of the Optometric Glaucoma Society, and the member of the Optometric Wellness and Nutrition Society. Currently works in Duncansville, PA, as an ocular disease consultant, with his primary focus is the management of anterior and posterior segment ocular disease. He's been a participant in multiple FDA clinical investigations and trial. He has integrated nutrition, prevention, and wellness into his patient care, and truly practices integrative optometry. He's a co-founder of the Optometric Education Consultants and a co-administrator of a nice resource called OCT Connect on Facebook. He has lectured extensively throughout the U.S. and other countries. In 2010, he served as president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 to 2016. And in 2023, he was one of the top eye doctors according to Newsweek magazine. So with that, nice virtual round of applause to my partner, Dr. Greg Caldwell, to talk about complication of pharmaceuticals every OD should know. Greg, take it away.
Thanks, Joe, and thanks for that nice introduction. And we'll just jump in here with our disclosures here. The first point is everything's been mitigated from all the powers to be and regulatory bodies. Lectured anywhere from Alcon to Dompe to or advisory board for Dompe to Iveric. I really have no proprietary interest in any of the companies or products I'm going to be mentioning tonight. Healthcare registries, I do sit as the chairman and advisory board for diabetes and macular degeneration, but truly these are the important bullet points. The content and the activity was independently prepared by me. No one asked me to stand up and, in a sense, do a commercial or help them with something. And then the content and the format of this course is presented without commercial bias. It does not claim superiority. If Joe and I do mention a product, it's not superiority. It's just we have to mention it. And I think everyone figured out that Joe and I are the owners of Optometric Education Consultants. With that said, I'm going to jump right in here. I'm going to open up the polling question. And it says, which of these complications have you seen? And I'm hoping that I set it up as a multiple choice. Have you seen the chloroquine, hydroxychloroquine retinopathy? So Plaquenil retinopathy. Have you seen those amiodarone corneal whorls or optic neuropathy that can happen with amiodarone? Have you seen pseudotumor or any other complication from, let's say, tetracycline analogs, the minocycline or doxycycline, and then we have ethambutol optic neuropathy. Have you seen those? So just kind of curious here. I see the responses rolling in. And which one is the most common? Okay, I think I probably could have picked that. I'll display the results here pretty shortly. This is that interactive. This is that synchronous part. This is the live part. You're able to participate. This helps us meet the regulatory bodies here. So thanks everyone for participating. All right, I think that's a good little trend here. I'll display some of the answers. And what we're seeing is 36% have seen Plaquenil. So a lot of people think it's like a unicorn. We always hear it but never see it. So that's good at 36%. It does happen. Kind of figured the corneal whorls, the amiodarone would be the highest. We have 15% with doxycycline or tetracycline. And we have 6 respondents to that ethambutol. So again, it's out there. So I'll close that question and I'm going to close the display and we're going to jump into the presentation here. So Joe has actually introduced me to Dr. Andy Lee, neuro-ophthalmologist, and Joe and Andy are friends. And by virtue of that, I have become friends with Andy, and he has one of his talks or his lectures, he talks about, these hate medications in neuro-op. and the hydroxychloroquine and amiodarone and tetracycline and ethambutol. And it was kind of neat as I was sitting through his lecture. I think it was up in Mackinac Island that I said, look, I have all of these in a case and scattered throughout. So you're probably going to see them all today in this complications course that's out there. These are all just kind of neuro-op type of medications that, in a sense, you can see optic neuropathy, pseudotumor cerebri, a swollen optic nerve head, optic neuropathy, and then, the retinopathy that can occur with the plaquenil that's out there. So I guess I'll jump in the polling question 2. I'll open that question up, and it is the complications of tetracycline analogs, which is minocycline and doxycycline. Which ones have you seen in the clinic? Have you seen that enhanced hypersensitivity where, someone gets out in UV and maybe burns a little bit quicker? Have you seen the effects on Coumadin or digoxin, the pseudotumor cerebri, the hyperpigmentation? And maybe Coumadin is not so highly seen as much because it's not used as much. But, the key with Coumadin is back in the day, Tracy Offerdahl taught me this one, is that pretty much everything will cause Coumadin to increase that pro time. So a little bit more with the doxycycline and minocycline, but digoxin is a cardiac medication. So. All right, so I think we have a good response. Everyone's warmed up on the polls. We have 63% seen in the photosensitivity. We have the secondary pseudotumor cerebri, and we have hyperpigmentation, 11 responses. That'd be great. If you guys have pictures, I'd love to have them. I'll put them in the presentation at some point, and I'll give you credit for it. So I'm going to close the question, and let's move on. All right. So in the antibiotic, the one that I picked was the tetracycline analog, doxycycline, minocycline. And this little cute little cartoon here is, maybe next time you should try a little sunscreen. Bacon has occurred here from the photosensitivity. Avoid in children, it's pregnancy, and avoid in children and pregnancy. In the old classification, it's category D. And we also want to be careful with breast feeding women. Stained teeth, small incisors, that can happen. It can enhance the effects of Coumadin. We kind of discussed that while the polling question was going on. And we used to say, idiopathic intracranial hypertension, pseudotumor cerebri, and this all kind of happened. And I changed it straight through from when I presented this one time, and we were out at dinner, and Joe sits back and he goes, "Hey, Greg, that was really cool. That digoxin case and all, or the doxycycline and minocycline case." He goes, "Yeah." He goes, "You see a lot of that swelling of the nerve." I said, "Yeah, once a quarter." And he goes, "Well, what do you call that?" I said, "Idiopathic intracranial hypertension." And he goes, "What caused it?" And I said, presumably the doxycycline, minocycline. We kind of had that conversation back and forth. Well, what do you call it? Idiopathic. What causes it? Doxycycline. What do you call it? I said, "Joe, where are you getting at?" He goes, "Well, if you know what's causing it, why is it idiopathic?" So that's why we call it a secondary, in a sense, in intracranial hypertension. And then we'll show you some hyperpigmentation here. So
yeah, I think we had about 5 cycles of that before I got my point across.
Yeah, it was pretty funny. I thought I had your slide in here. It might be coming up that I'll have you walk through here. But yeah, I think that was about 5 cycles, but it was pretty fun. So thank you for enhancing me and then taking it out to the colleagues that's out there. So here's a bilateral swollen optic nerve. Unfortunately, and I'll let Joe, this is more his wheelhouse and expertise. This patient came in, bilateral swollen nerve head. You can see it's a little bit of hemorrhaging there, maybe going on, some hyperemia. And, you have to send these and get MRIs. Joe, taught me, I said, "Look, they're even on doxycycline and minocycline." He goes, Yes, but they can also have a brain tumor too and be swollen from this. So we don't want to really miss anything. So Joe, you want to talk about these bilateral swollen nerve heads and maybe a quick how we're supposed to work this up if we see this at our office?
Sure, something like this. It is so, the nerves are so obscure. There's so much hemorrhage there. There's exudation there. There's cotton wool spotting. This is relatively acute. This is not a chronic thing. So that means we have to jump on this urgently. First thing you want to do in bilateral swollen nerves like this is check blood pressure. It can always be malignant hypertension. So always check that first and foremost. Also, make sure you understand what the visual acuity is, pupil defects, pinhole acuity, visual fields. We need to see how bad the visual, if you can do all of this. But this is a person who's going to need an MRI of the brain orbits and chiasm with and without contrast. Brain is going to be most important. If you're suspecting a pseudotumor situation, you're going to be asking them to also look for flattened globes and empty cell tersica. You also note a MRV, magnetic resonance venography, looking for venous sinus thrombosis. Something like this, if there is vision loss at that time, you really need to do it urgently. I would do it in conjunction with the ER, but don't just send them to the ER. Send them to the ER, telling them what you think that it is and what testing needs to be done, because otherwise they're going to get a non-contrast enhanced CT of the head because that's their hammer and everything is a nail. It's what they do. Once they're done with that, they tap out if they can't get a consult. Give them a consult in advance. But if there's vision loss involved here, it is an urgent situation. Probably best to work it with the ER.
Thanks, Joe. And then you have to go through all that. Unfortunately, you're going to hear me say in a slide or two that, I see this once a quarter in our practice. We have a 5OD practice. We get these bilateral swollen nerves. It's kids using it for acne. It's adults using it for acne. It's adults using it for maybe Lyme disease or something chronic and using it for an anti-inflammatory. And, I feel 100% or 90% or 99% that it's the minocycline or doxycycline, but I don't ever want to miss, that thrombosis, that brain tumor that's out there that this patient could be having. So they went through the
Yeah.
workup and basically we discontinued the causative agent, the minocycline or doxycycline, and whichever it was for this case. And the timelines are still here. They still work well. The note's 14 years ago, but here's the original nerves. You can see we stopped the causative agent, and 12 days later, you can see those nerves start to reverse from the minocycline or doxycycline. 25 days later, you can see that the left eye here is still a little bit more swollen. The right eye is almost returned to normal. 48 days later, looking pretty normal in both eyes. So
And
just
Greg, it's important to emphasize, stopping the causative factor came after the evaluation was done to make sure there's nothing else going on, of course. With a presumptive medication-induced pseudotumor situation, it should be your diagnosis of exclusion, which is your last diagnosis, not your first diagnosis. I try to teach people, making a diagnosis of exclusion your first diagnosis is what I call killing patients the old-fashioned way through misdiagnosis. Interesting, Greg, I haven't I haven't mentioned this to you yet, but a trend that I've been noticing, and this is pretty honest, we have a lot of phone friends, people I've never even met. Maybe Greg hasn't never met them, who reach out and ask, what to do in certain situations. One thing I've been finding, Greg, on a lot of our phone friends, they're now calling, not asking what is this or where do I send it, but people are calling or texting asking, what study do I order? What blood test do I order? It's sort of, they're now getting more involved in doing it themselves, which I've just been noticing in the last couple months. So that's actually pretty gratifying. CE does help.
Yeah, it's pretty fantastic. Yep, absolutely. People, I always talk about the 4 C's, right? There's, people want to have commitment, people want to have confidence, and capability, but you always have to have courage and commitment to get there. So that's what they're doing. They have the courage and the commitment to try and help these patients. That's fantastic. All right, here's your slide. Joe, you want to go through it, Joe? Here's the pseudotumor and what we want to call this patient, and rather than it's a secondary pseudotumor.
Yeah, and I'll go through it briefly because we've covered some of it, but everybody seems to think pseudotumor is an old term, and idiopathic intracranial hypertension, or IIH, is the new term, and it really isn't. Pseudotumor means increased intracranial pressure, but there's no tumor, there's no tumor. But there are causative agents that have been identified, such as venous sinus thrombosis, medication, certain vitamins. So if there is a secondary cause of venous sinus thrombosis, a medication use, we call that a secondary pseudotumor. Now, if none of that is there, we can call that a primary pseudotumor, and that's IIH, or idiopathic intracranial hypertension. And these are usually the younger, overweight females. They don't have to be obese. They just have to be a little bit above ideal BMI. And this is mostly due to poor CSF drainage. So these medications are often inhibiting CSF absorption at the arachnoid villi, or the venous sinus thrombosis is just that it's not letting blood or CSF out of the brain to circulate. So it's going up. If there's no secondary cause, IIH, or primary pseudotumor. If there is some sort of identifiable cause, secondary pseudotumor, or pseudotumor is still a good term.
Perfect. Thank you. No tumor causing it to back up. So again, this is just a reminder that, I do see these from time to time. You can see the swollen nerve head, causative agent is discontinued. Again, as Joe mentioned, they've gone through the workup, and you can see that nerve returns back to normal. Here is the other eye showing that it was bilateral going and improving, and then slowly returning back to normal over the course of maybe that 48 days. So it's out there. So yeah, every time I see this, I just try to remind everyone that, medications can cause this, but they still have to go through the workup. And
before we move on, Greg,
yeah.
I'm sorry, there's a question. Somebody asked, only MRI or MRI and MRV for bilateral swelling? MRV is necessary. So both, in terms of suspected papilledema, MRV has to be done. Looking for venous sinus thrombosis. That means CSF is not flowing properly through the right channels, and that's why the intracranial pressure goes up.
Perfect. I'll have you
That's
police
it.
those if you watch it. It's good. Thank you. So here was, a patient that came in, and, I said, her name's Mary. And I said, hey, Mary, what's going on? She's here for a blepharitis check. And she goes, oh, everything's great. And she goes, the only thing is that, no one can really figure out what's happening to my legs here. She's wearing long pants. She pulls up her pants, and she's like, here's what's going on. She's like, I had biopsies, this and that. And I literally went, and Mary goes, hey, doc, why did you go like this? I said, I did this to you. I said, don't you remember? And I said, pigmentations can really happen all over the body, and this can happen. And she goes, yeah, but to this extent? I said, that's exactly the extent that this can happen. So I was treating this patient's meibomian gland dysfunction. She was on, doxycycline, well over a year, started off 50 milligrams, maybe twice a day, got her down to, once a day. We got a pill cutter. She was able to cut and just take 25 milligrams. This is what happened with 25 milligrams, after 18 months of being on doxy. She just gets this hyperpigmentation. She was a dermatologist, had a little biopsy. It's not really necrotic, just a bunch of pigmentation that's out there. So again, we identified the causative agent, and you can see that over time she began to fade. There's what she was originally, and here's where she is, 6 months later, improving. This is where she was a year later. You could see that she almost got back to normal. And there's where she was, a year prior to. So, if you want to have some fun, if you want, you could just go to Google, type minocycline hyperpigmentation. That's the only 2 words you have to type. hyperpigmentation, minocycline, hyperpigmentation, doxycycline, hit enter, go to images. You'll see that this can happen all over the body, and it can be permanent. The other thing I always like pointing out is when I see patients coming in on doxycycline and minocycline, I warned them of that, and they always say, "Oh, no one's really told me that." And it's been funny because I've had patients come in for their eye exam. I'm seeing them every 6 months, and they go, "Hey, is this the pigmentation?" Or I have some people that have kind of some Smurf fingernails, and I said, "That's it. You got to call your primary or call your doctor that prescribed it to you and let them know that you're having that pigmentation." I'm going to kind of skip back to this slide right here because I have this. I should put this in the slide deck. And I do have this kind of typed up. Anytime I use doxycycline, sometimes I get some people with Lyme. Sometimes I still want to clean those meibomian glands up. And I just have this in there. They are risk, benefits, questions, answers. RBQA, discussed about doxy, discussed about minocycline. And I say, look, and it just reminds me too, I have it, I can click on it in the electronic health record. I say, I have it all typed up, like discuss with patient, risk benefits, questions, answers, discuss with patient, enhanced photosensitivity. We need to avoid in, children and in breastfeeding. I can delete that out if it's, if it's a male person. It can enhance, medications such as digoxin and Coumadin. It can create a secondary intracranial hypertension, nerve swelling, and create hyperpigmentation. I have that in there and I can click on it, and it's nice because I can turn around and literally kind of modify it and then, show that to and go over all those risk, benefits, questions, answers with the patient before placing them on it. So, that's what I have for this patient here. And, it was so intense that it still didn't even, reminder that it was, that was the causative agent. So, Joe, anything in the chat box before I move on to antivirals?
I will check one more time real quick. Nope. The last one was the MRI, MRV question. We're good.
Fantastic. All right. So let's move on to antivirals and, the acyclovir. We're going to go back to the herpetic eye disease study here. And are there any differences in the antivirals? Well, one of the major reasons people dropped out of the herpetic eye disease study was basically gastrointestinal side effects. And sometimes if you use acyclovir or back before, Valtrex became a generic, you'd have these people come in and, they'd say, yeah, I'm having a little GI upset, but, they can muscle through it if it was like a simplex or a zoster because they really weren't on it chronically, like the herpetic eye disease was using 400 milligrams twice a day. So working with Tracy, the pharmacist I lecture with, we were just sitting around one day and looking through some literature, and it really came across that the thought was, why does this happen? The difference is when you read, it really wasn't the active ingredient. It's these inactive ingredients. As you can see, there's starch and, sodium and all these other different types of titanium dioxide, but they each basically acyclovir and famvir, which really isn't used much, has lactose in them. And so this is just another advantage of why using valacyclovir or Valtrex, there's no lactose in there. It does absorb a little bit better than acyclovir. It's a prodrug, as you can see. It says valacyclovir. It's a prodrug that's out there. So I wanted to point out that there's some lactose. If you're ever trying to figure out, should I use acyclovir for those zoster patients, those herpetic simplex patients, maybe lean towards Valtrex, for a couple of reasons out there, this being one of them. Another side effect that can happen with the antivirals is this kind of CNS type of effects. I had it happen to a patient. This lady could not have been more than 95 pounds, wet and with cans of soup in her pockets. And she comes in, she was, moved from the Pittsburgh area up to this area where I live. And she had bilateral cornea transplants, maybe 2 in one eye or 3 in one eye and 2. She had bilateral cornea transplants. The other ones, rejected because of a herpes, zoster, reactivation, and all that fun stuff. And they had her, on like 1,000 milligrams 3 times a day of Valtrex. And she was kind of having these Charles Bonnet type of hallucinations, right? Charles Bonnet hallucinations, when people get to about 2,200, 2,400 in their better eye, they can see images. This lady was still, about 20 bilateral cornea transplant. She was about 20/50, 20/60, best corrected. So she didn't have the reason to have Charles Bonnet, but then she was taking all of these medications, and I slowly just ratcheted her down to about 1,000 milligrams, just kind of a maintenance dose, and her hallucinations went away. So just be aware that these do have some CNS effects, higher dose, and carrying on for, for long periods of time. Most of the time we optometrists are not, prescribing. It's kind of more of an acute situation with the zoster, the simplex, but there are times when we get into these chronic usages of these, and just be aware that, there's the lactose and there are some CNS effects with these antivirals. Jumping into the alpha-1 blockers, floppy iris syndrome can occur. And this can happen, probably the biggest one is Flomax that's out there. Really, this can happen at the time of dosing, and even if they discontinue, this iris muscle remains flaccid. So just kind of, look at all these different types of, kind of medications that are out here that are alpha-1 blockers that are used. And, we try to identify these for our surgeon anytime we send a referral. The surgeons will definitely always ask, because, the pressure is high in the iris or high in the eye when they make their incision, and that iris being floppy can come out through the wound, or, it just makes it hard while they're phacoing. And there's some tricks that they can do at the time of surgery using, different type of viscoelastic, keeping the pressure high, whatever all the tricks are that the surgeons can do to kind of keep that iris, but they just kind of need to be warned that's out there. So just, just remember, floppy iris syndrome can occur. And I want to warn you on this. This happened probably now 10 years ago, but always worth talking about, because more and more optometrists are getting involved in post-op care. This was a patient, again, floppy iris. They usually don't dilate as well. So after 4 rounds of phenylephrine, tropicamide, cyclopentolate, there was poor dilation. So the surgeon used some iris hooks. They had to pull that open. They had to use a little bit more viscoelastic. And patient comes in 1 day post-op. We warned the surgeon, but forgot Dr. Caldwell about this. So 43. So in those cases, a lot of time, the patient was probably higher. They said they had a lot of pain overnight. So I certainly don't mind burping the paracentesis, right? Not the main wound that's done. The surgeon usually has a main wound, and then they work through a little paracentesis to kind of maybe move the lens around and assist in cataract surgery. So you can literally take, like I've heard people talk about, like the dilator for a dilation irrigation. You numb the eye, maybe put some betadine in the eye, and then you can push. I usually use like a jeweler's forceps, just get right below where that wound is and push. Well, I did it on this patient and brought some iris with it too. So it's kind of neat under the microscope. The first time you do it and you burp that paracentesis, under that 20 magnification, it looks like the whole anterior chamber comes out, because it is, once you get it open, it comes skirting out. And, I've done it enough times, but forgot this patient was on an alpha blocker. A little bit got trapped in that wound. That's not good. Had to call my surgeon up. And luckily, the surgeon said, well, I've done it before. I'm in surgery center, a little bit later today. I'm seeing patients in the morning here. Send them over. And he used a little, irrigator and aspirator and pushed the iris back into play. So just be aware. I know we're doing a lot of, post-op out there. Just be aware of those patients that have those floppy irises, because you can bring it through the wound just as the surgeon can bring it through the wound.
Greg, just to throw a couple quick, if you want to start the poll, is it a poll coming up?
Yeah, let me do that, and you can do your
Yeah.
comments. So,
All right.
so let me just read the poll here. I have
Mhm.
seen cornea verticillata cause a vision loss. Yes, no, or there is no way it can cause vision loss. So poll's not open yet. I'm going to open it up right now. Joe, make your comments, please.
Yeah, talking about the post-op pressure spike from the viscoelastic. Couple little pearls. One, as Greg says, you want to see where the paracentesis, not the surgical wound. And it actually helps to know if the surgeon is right or left-handed. So you know exactly, that the dominant hand would be doing the surgical wound. One of our surgeons is left-handed. It's good to know that. Now, Greg, I personally don't burp wounds for, the potential complications. My wife will do it. I don't know why she does it. She did it once and had a patient go into a syncope. She did it once. Patient came back next day. Pressure was still up. Great. I always do Diamox. I'll do a couple in the office, couple for dinner, couple for breakfast the next morning, some COSOP PF, couple little vials. Virtually every time pressure 55 will come back down to 20 or under.
Yeah. Yeah, I probably the pearl that I would have is if the patient's in pain, I usually just relieve the pressure because they'll feel immediately. They're like, oh, doc, thanks. So, every pressure comes in. Do I burp and be a cowboy? No, but if they kind of suffer, then their pressure's still up, and they have a little bit of ache, I'll just burp it and bring it down. But so, I have done the Diamox and I'll even use COSOP 4 times a day in that eye. People are like, oh my gosh, 4 times a day, it's BID. Well, what happens if I put 2 drops in this eye and 2 drops in this eye? It's still 4 drops they're getting. So what happens if I just put them all in the same eye? So I can do COSOP QID. I do Combigan QID on those patients that are out there. So yeah, good points. All right, let's see. I'll display the results. We have I seen cause vision loss? 70 or 88% say no. And we have 7 responses or 8% saying yes. And we got 4 people just saying, hey, listen, it does not cause loss. Well, that's why we take education, because it's out there more than you think. So let's talk about amiodarone. Treatment for cardiac arrhythmias. Most of the time, it can create that corneal deposits on patients, and usually bilateral, with 10% complaining of blurred vision and halos. We also have to remember it's one of those hate medications that's out there, and it can create an optic neuritis, some type of optic neuropathy that can occur. So here we're looking at, patient is taking that oral amiodarone, and I'm going to say that way, as when I get to another cause of verticillata that's out there, the pattern's a little bit different because it's more of a topical administration rather than an oral. So we have amiodarone here, and found that there's different stages. Whenever I had my patient that I realized it was creating that vision loss, right? So there's different stages here: punctate opacities in the horizontal linear manner inferior cornea. Basically, stage 3 is whenever it starts to lose vision, that increased number of branching patterns in the inferior pupillary area into the visual axis. So there's a different grading. I just put it in there more for completeness. I really didn't realize that there was a grading scale, but there was always a grading scale for everything. 1, 2, 3, 4. That's out there. So let me just show you the patient that I had. This was a 64-year-old woman. She reports decreased vision over the last 9 months, especially at near. And that's where I really see, and maybe it's because, I don't know if they're looking down and kind of looking down through that verticillata, or, the cat out of the bag is the irregular astigmatism might be more pronounced and cause more near vision loss than at distance. But, she's best corrected both eyes, 20/50, 20/50, and 20/50, right, left in both eyes. So when I look at her, you can see she's pseudophakic, maculas are crystal clear, and she's 20/50. So I decided to do topography, And I'm really big on topography. If you're going to have a topographer at your office, we kind of need to know what's happening. It's kind of hidden here. We have to take away all the logos, not to promote any companies out here. But you can see is that it says the posterior float. We have an anterior float, right? So the posterior part of the cornea where the endothelium has a curvature. We have where the epithelium has a curvature. And then with that being said, we can kind of get an optical pachymetry reading. But when you look here, you can see that the anterior surface, it's pretty steep in some areas, right? And we go from 46 to 43 in some of these areas. And that was the right eye. You can see over here, the left eye, again, the posterior float looks pretty good. The anterior float looks pretty decent. But when you look at the keratometric part of it, it just doesn't look, doesn't look well. So basically what this is it's irregular astigmatism. Now, this was a fun case because this is a call to the cardiologist, and called the cardiologist up, and I, faxed over, and it was black and white, but at least the cardiologist had the topographies. We had this great conversation. They're like, listen, they taught us that it never creates vision loss, that, it's, maybe this optic neuropathy thing, but you're talking about the cornea here. And I'm like, listen, there is irregular astigmatism. So the cardiologist says, look, usually the, amiodarone is kind of a last ditch effort. We really can't switch. Maybe the patient's working on 10, 15%, but this patient was able to be switched, luckily, so it helps the case go along, come out even more positive. So the cardiologist said, hey, all right, I know you've been in town, Greg. You do all these kind of fun cases over the years, good reputation. Let's go with it. So he ended up switching the patient off, and the outcome was pretty cool, right? Check out the same patient. You can see posterior floats, anterior floats, the optical pachymetry, but take a look at the original keratometric reading versus now look how more regular this looks. And the patient, because they're pseudophakic, maculas are clear, so on and so forth, went to 20/25 best corrected acuity in this right eye. So it's the irregular astigmatism that causes the vision loss. And one of the pearls I always like to point out is, I usually like asking the audience live is, what's the power of an eye, the overall power? And everyone usually says about 60 diopters. And I say, okay, what's the power of the cornea? Well, it's right here. We look at it all day long. Down here, this one is 43 and 42 and 44. So 40 over 60, it's about 2/3 power. That cornea, when it swells or becomes unhappy or irregular astigmatism, remember, the cornea is 2/3 power of the eye. So it doesn't take much unhappiness to that cornea to cause a decrease in vision. And that's why we're all big on dry eye and, ocular surface, and the surgeons that are doing all those specialty IOLs really want that cornea to be, really, pristine. As a regular astigmatism like this, I wouldn't be putting a multifocal patient spending $6,000-8,000 per eye to get specialty lenses done. Maybe, I know she's already pseudophakic, but maybe consider a specialty lens here now that irregular astigmatism has improved. Here they are side by side. There's the right eye. And I can tell you, do I call the cardiologist and change medications every time I see this? The answer is no. Have I seen people be best corrected 20/25, 20/30, 20/40-ish? The best corrected acuity, more than those 20/25, 20/30 range. I'll run a topography on them and they have irregular astigmatism. Patient's asymptomatic. I talk to them about it. Again, their heart is working at a very low capacity. But have I called the cardiologist over the years, and have I had them switch medications on some more severe losses? And the answer has been yes. So just kind of keep that in the back of your mind with this. And this was the left eye. I think I showed you the right eye earlier. This is the left eye 6 months later. And you can see the dramatic change in that irregular astigmatism. And there it is with the left eye side by side. That's out there. So, it does create vision loss. Is it worth, calling up the cardiologist? The cool thing is the cardiologist in in my area, he was a lecturer too. He presents this case, so he gives me credit. And my optometrist in Altoona, Pennsylvania, when he talks to his cardiology friends, we're all been taught that it doesn't cause vision loss. So he brought this, at least cornea vision loss, that's out there. And so he gets to go out and spread the word to his cardiology friends. This is a 67-year-old man complains of vision slowly deteriorating over the past 8 months. And really, this was coming into me. I thought what it was, and then I got him down into what is it? Down in the Maryland area. It just slipped my mind. Walter Reed area down there to get kind of the to get an evaluation. Because this was a 67-year-old man that came in, the decreased vision over 8 months. He has a history of a non-arteritic ischemic optic neuropathy, right? 10 months ago. I got the records, and it was, in a sense, non-arteritic. Worked up. The GCA was, at least the blood work was done, and actually looked at all 4 findings. The complete blood count, checking out the hemoglobin, checking out the platelets, a C-reactive protein was done, SED rate. And really the patient hasn't been to, primary care physician for 35 years. And there's non-arteritic, maybe there's a heart problem issue, and put on some, Cardarone, and his vision 9 months in this eye that had the non-arteritic ischemic optic neuropathy was 20/80, and he was 20/25, and he comes into me, 2400, 2200. You'll see confrontation fields very constricted here. He had the corneal vertex whorls. It's not the irregular stigmatism causing the loss. Here were his visual fields. And you can see here, just 0, 0, 1, there's a 12 and a 17, all zeros. And a reminder, the zeros is the brightest light. So the smaller the number, the brighter the light. And you can see we're just severe defect. And for you have taken my visual field lecture, one of the pearls I like to point out, like a blind eye in about a 65-year-old person is like minus 32. He's minus 20. And over here, he's minus 30. So a little bit worse in the right and the left, in the right eye compared to the left eye here. So you can see that's why it was 2200, I guess. He's got this little area. Maybe he can find that 200 spot, and the letters just aren't big enough in this eye because he's literally blind. So, my diagnosis at this time was, amiodarone optic neuropathy. I've, been lecturing on this for years, never really saw one, but it's more of a diagnosis of exclusion, right? This is a person that had, an optic neuropathy. And this was a case before I knew Joe and before I felt more comfortable working these up. And then on top of it, the guy's literally blind and been to a bunch of eye doctors in the area. So we ended up sending him down, to like one of the teaching hospitals, and they literally put him through every test. Like Joe would say, MRI, MRA, blood work, looking for infectious, looking for inflammatory, and basically came to the diagnosis of an exclusion of an amiodarone toxic optic neuropathy. And these are his just pale optic nerves here, more toxic, ischemic in a sense with his. So this is my only case. Luckily, I haven't seen any more, but I see that there were some of our colleagues that did have seen this in the past, maybe. So, Joe, any comments on toxic optic neuropathy, amiodarone?
Well, you're right. It's a diagnosis of exclusion. You've got a potential causative factor, but you still have to do all the evaluations because there could be something else going on. That's why the MRI, with and without contrast, brain orbiting chiasm, that's the only way you can get all the optic nerve is to do that, those 2 scans. And unfortunately, just stopping this medicine is not going to reverse it. But once you've ruled out everything else, you may want to talk to the cardiologist, see if she or he will stop using a medicine to retain what little vision that they have. Now, interesting, I've looked a close couple times on this left eye, Greg. It almost looks like there's, some android streaks in there. I might be imagining it, but almost looks like there's a couple nasal to the disc. That's just I think coincidental if it's there.
You talking about this?
No, other side, way
Oh,
over.
over.
Right, yeah, right there. That vessel going right now, right about. Keep going. Yeah, it looks like right about there where it is. And it doesn't look like a vessel. Could be a portal vessel, but I
Oh,
think it
I
almost
see
looks
now.
like an android streak. Hmm.
Okay. Yeah. So it's my only case, but falls into complications every of pharmaceuticals every optometrist should know.
Interestingly, why don't you start this one? I'll make a comment while it's going on.
All right, I have used Netarsudil, which is in Ropressa, which is solo agent, and then Rocklatan, which is latanoprost, and the Ropressa or the Netarsudil in my treatment for glaucoma. Yes or
You
no?
know,
Just curious.
that reminds me of a story from two neuro-ophthalmology friends of ours, Valerie Buse and Nancy Newman, talking about a case where there's an optometrist who saw a patient and there was vision loss, but didn't do a great enough history of medications. Referred to ophthalmology, and the ophthalmologist just took the optometrist's medical history and didn't do a history of his own, and didn't realize the patient was on Pacerone or Amiodarone. The ophthalmologist referred to the neurologist who did a better medical history and saw the patient was on Pacerone, but didn't recognize that Pacerone caused optic neuropathy. So it was a kind of unfortunate case that couple doctors kind of looked over. So yeah, you're right. It's an important complication every optometrist needs to know.
Fantastic. So here we are, polling question rolling in. I have used Netarsudil, Ropressa, Rocklatan in my treatment of glaucoma, and I'll share the results. And we have about 20%, 18% that have, and we have the majority, whether treating glaucoma or not, have not reached for Netarsudil. I'll give you my pearl on Netarsudil here very shortly. I'm going to close that poll and close the display so it's out of your screen. And let's jump in. So, Repressa came out by Aerie Pharmaceuticals in 2017. It recently that molecule was acquired by Alcon. So Alcon is now coming back, and you can see they have a portfolio of medications, and it's kind of neat how it came full circle, because really Alcon was, when I graduated in 1995, 1996, they were kind of the big boys of optometry, and then Allergan came out, and now we're into other types of, we got Tarsus out there now, and now Alcon's making the full circle. So Alcon owns this molecule, but it was approved in 2017 for the treatment of glaucoma and ocular hypertension. This is a Rho kinase inhibitor. It's used once a day. They did find that using it twice a day was not very well tolerated, but with this medication comes some new side effects: the conjunctival hyperemia. There's the cornea varicillata, but remember, this is topical, and conjunctival hemorrhaging that's out there, and I'll give you my opinions on that. This is what's on the package insert, and I'll kind of give you my thoughts when I show you a few slides here. It's really cool the way this medication works. It actually goes and targets the trabecular meshwork. Nothing really trickery here. The trabecular meshwork, you can see, is compact. It goes in and works on the actin and myosin, kind of expanding the trabecular meshwork. I think we all probably realize that glaucoma is a disease of outflow. That's why we've seen so many types of procedures, starting with ALT, kind of burning that hole, SLT, thinking we kind of activating something, maybe the mitochondria in there. But we have all these MIGS procedures that are out there, these minimally invasive glaucoma procedures that are eye stents and Cahook dual blade, and all these goniotomies, trying to just kind of get rid of this disease trabecular meshwork. And here, what we're just using is a medication to expand it. Pretty neat concept that's out there. This is my clinical pearl. Netarsudil works just as the clinical study shows. It's going to lower when it works, because it works in most people. When it works, it lowers 4 to 5 millimeters of mercury. So you have a patient that comes in and they have a pressure of 25 or 28. You're not going to get that lowering effect that you will with like a prostaglandin analog. However, you will get that 4 or 5. It's just kind of steady. Where this medication shines is we all know it's hard to lower a low IOP. 16s to 11s. I've seen 14s go to 8s and 9s. So it just kind of has a nice kind of steady lowering effect. To me, the clinical pearl is this medication lowers a low IOP. So just kind of put that in the back of your mind. But this is complications. So what are the complications that occur? So the indication, there's no labeled contraindications with Ropressa. It doesn't affect blood pressure or heart rate, because when Ropressa, gets tested, it has to get tested against a single agent. The single agent was timolol. Timolol did what it was supposed to do in the cohort or the study group. It did lower the blood pressure and the heart rate, where Ropressa did not out there. However, it did come again with these new kind of ocular side effects. They say conjunctival hemorrhaging. To me, yes, there's hemorrhaging at times, but what I see is more of a vasodilation occur. This medication does work on the kind of the venous side of the system. It has been shown to lower the episcleral venous pressure. So this kind of vasodilation. So where they would maybe call this a subconjunctival hemorrhage, it's more of vasodilation. And the beautiful part is maybe over here some hemorrhaging, but this here, what they're showing is not really, to me, hemorrhaging. Maybe here is hemorrhaging, but there's also some vasodilation going on. So that's one of the, kind of newer side effects with this medication. What I do want to point out, though, is if you can just kind of have the patient kind of hang on for 4 to 6 weeks, you kind of get this kind of red eye, and then things kind of calm down over time, but you still get that IOP lowering effect as the side effects occur. Now, the cornea verticillata that's out there is this phospholipidosis. It's the same type of thing that happens with amiodarone. Okay, here's the control. We're looking at kind of microscopic down at the level of the cornea, getting into the nitty gritty of the cellular matrix. And the Netarsudil and the amiodarone kind of do that same thing with that phospholipidosis, creating that pigmentation, that kind of whorl-like pattern that occurs with the patient. And this is taken right from the study that was out there. I think it was those rocket studies 1, 2, 3, and 4. When this one came to these phase 3 studies, this is right from their website, right from their papers, their medical science liaison. And this is the pictures that they showed. Almost looks like that amiodarone type of third up, 2/3 down type of cornea verticillata. I'm going to show you the first time when I recognized that it was happening. It looked a little bit different, and that's why I'm kind of going to highlight that kind of topical type of administration, which is right here. This patient, I don't know, they had a unilateral type of glaucoma. We were only using it in one eye, which actually even made it, even better for me for teaching purposes. And so, patient comes in, and this is typically what we see with this is the patient I showed you earlier with the oral administration. This patient comes in and they got this pigmentation. And you can see it is all over this cornea, right? And here is no pigmentation over here. So I start thinking about all the different types of bad things that could be happening with this patient. Joe, what's the condition that Al Moyer he works with the company and talks about the cornea deposition? Do you know what I'm talking about?
Fabry's disease.
Thank you. Fabry's disease. So I'm thinking, oh, this is I got a case of Fabry's here, so on and so forth. Go over and look at the other eye. Well, it's not bilateral. This one's perfectly clear. Come back over, it's glaucoma patient. I have them on the Netarsudil. And I literally laughed out loud. The patient goes, "What are you laughing at?" I said, I talk at this lecture complications, and I, have these slides here. I'm talking about all these new complications that are out there. And in my mind, I just diagnosed you with Fabry's disease and all these other kind of crazy conditions from, cornea pigmentation. And it's the drop I have you on. And I said, I just realized that, it doesn't have to be this kind of a whirl like third up, 2/3 down. Since then, I've had plenty of other cases come in, and they don't always look like this, a third up, 2/3 down that's out there. And I've seen it in bilateral presentation. I haven't had anyone get to the point where they get the irregular astigmatism and lost vision. I've talked to the MSL of Erie and Alcon, and they haven't had any reported cases that are out there. However, I've had patients that, didn't like the redness and so on and so forth, had the pigmentation, and when you stop the medication, I have seen reversal that's out there with this medication. So that's Netarsudil, kind of the difference in the Amiodarone. To me, there's a difference because it's topical administration versus this one coming in orally. And I always like looking at these because it kind of shows you how the cornea heals, right? When we have an abrasion, we kind of get the, that kind of pseudodendritic appearance where that wound gap comes together as the abrasion heals. I always kind of like looking at these because these are kind of like, to me, kind of like tracer molecules showing you how the cornea epithelium kind of heals from that limbus. Joe, you have any comments or any questions that have rolled in from the audience there?
No, the only question that came in that I think we indirectly answered before the question came in was about the amiodarone toxicity, optic neuropathy, and is it reversible? And the answer is unfortunately it is not.
Yeah, that one is not.
My only comments about Netarsudil or the combination Rocklatan. You will get Versalata. I mean, it happens. It usually isn't sort of an issue. Now, I've actually used these medicines. I have glaucoma. I think I caught it from a patient. I'm pretty sure I know which one. And I've tried all these medicines. I will tell you, like I got the only one that gave me redness and hyperemia was Rocklatan. It was pretty significant. It lasted several days. Usually within about 11 days has been my experience. The redness goes away, but it just blurred my vision. And I don't really know how to tell you it blurred my vision. The quality just was, it wasn't good quality vision. My Snellen probably didn't change at all, but I've got floaters being a high myope. It almost seemed like made my floaters thicker. So I stopped using after several days. It went away. I used it again. It came back. So for me, it gave me some mildly blurred vision.
Yeah, those are good points, and taking it from a personal standpoint. I think this medication does something at the endothelial cell level, and maybe you were getting some type of that type of action.
No
Again,
idea.
yeah, and maybe with
No
that,
idea what it
again,
was.
2/3 cornea, power. Maybe that's what you were picking up on. So with a 20/20 acuity. So, and then just a reminder: the Netarsudil, hyperemia, Versalata, and conjunctiva. Joe, I pulled this. I hope it's not much of a surprise. I know you've given this enough
Not at
times.
all.
I pulled this from another presentation. I thought we should put it in here and have you. And I've seen you discuss it. These angle closing medication, drugs that cause angle closure. Can you just take it, and I'll advance the slides when you tell me.
There are a lot of medicines that can precipitate I guess you can say an allergic response or idiosyncratic response that leads to choroidal congestion. Believe it or not, acetazolamide, the Diamox, which we use for angle closure, can actually cause angle closure if they have a sulfa allergic response. And these are all things that have a relatively small N number in case series. The only one that really stands out is topiramate or Topamax. It is anti-seizure medicine that has been used. I say off-label, maybe it is labeled now, for a headache, for mood disorders, for weight loss, to decrease the psychological dependence on alcohol. I mean, it probably has more off-label uses than it has label uses, but this is one that really does stand out. You can advance, Greg. So what happens is it can cause a congestion or a ciliary effusion where there's an anterior rotation of the ciliary body. So this can reduce tension on the zonules, and the lens is going to thicken, but it doesn't lead to a pupil block, believe it or not, but it does induce myopia. And this is the symptom that bothers patients most. It's the sudden blurring of vision. So it induces myopia as the iris lens diaphragm shifts, and leads to a shallowing of the chamber, not an iris Bombay, but a collapsing of the chamber with potential for a true angle closure. Next one, Greg. And I like this this diagram or this illustration. We see the ciliary body, the iris, the angle, and these medicines, particularly topiramate, can cause I guess you can say a sulfa allergic response. You know, the best description of the pathophysiology I have ever seen on this was actually in People magazine. Topamax was a new medicine that was being advertised for migraine headache in all places. People magazine, you see the nice ad, then you turn it over, and there's 4 pages of product insert. And they really had a good description of the pathophysiology. And this is an idiosyncratic sulfa allergic response or sulfur response that causes a congestion of the ciliary body. You see how much it really just swells. And when that happens, you're going to have a collapse of the anterior chamber. If you want to go ahead to the next one. And these are bilateral. You can look at the von Herrick angles, and you can scoot across with your beam on your biomicroscope to mid cornea, and you're going to see a very, very shallow chamber. You see in these OCTs, they're not. There's no iris Bombay. It's just a forward rotated iris collapsing the anterior chamber. And the key here is there's no pupil block, and since there's no pupil block, there's going to be no benefit from iridotomy. And it is bilateral. Most primary angle closures, acute attacks, are going to be unilateral. These are typically bilateral. Greg, if you want to advance. Case, 39-year-old female, recently started on Topamax for migraine, and suddenly has onset blurred vision, a little bit of eye discomfort. She never wore glasses before. Now she's a 6 diopter myope, and she refracts down to close to 20/20, and her pressure is 44. And this is, and these are bilateral. This is really a classic example. Now, when I was on university, I had a colleague telling me about a patient that she had who was on Topamax and was telling me that, well, I'm going to watch this patient every 3 months with gonioscopy, and as soon as she starts to narrow, I'm going to refer her out for an iridotomy. And I said, that's great, but none of that's actually, correct, because it's not a buildup. It's sudden. One dose is enough to do it. If it doesn't happen within the first week, it's probably not going to happen. It usually happens within the first day or two, sometimes the first dose. And as I said, iridotomy does nothing. It's not pupil block. Greg? Advanced forward, I think. So this is a situation where you stop the medicine. Now, I'm not going to stop it if they're on it for seizures without talking to the primary care physician. But if they're on it for another reason, I'm going to stop and let the PCP know. And they're always going to be grateful for you to doing this. Stopping the medicine, no Diamox, no pilocarpine, no iridotomy. Use a steroid, a cycloplegic, and an aqueous suppressant. We see what happens. It will resolve. Now, the myopia will linger, sometimes several weeks, but the angle closure and the pressure usually responds pretty darn quick. I think that's it, Greg. So we got to consider choroidal expansion, choroidal effusion, and sometimes a cycloplegic and a steroid may be a better option than pilocarpine, because the atropine will work by moving the ciliary body and improving the forward diffusion of aqueous. I think that's pretty much it. If there's anything else we want to talk about there, Greg.
Yeah. That was it. And I added these slides. So for those that have the handout in front of them, I added this slide in here really 10 minutes before the presentation, just because we talk allergies. Joe talked about self-allergy here. So this is not a polling question. Just ask yourself, have you ever had a person allergic to a self-antibiotic? But you're like, you have glaucoma and I want to try lowering your pressure, and you've used maybe Cosopt or Azopt or Trusopt, which is a carbonic anhydrase inhibitor, single agent, timolol and dorzolamide in the Cosopt, and maybe even Diamox, and the patient really didn't have any problems. So, what's going on? Yes, you have. No, or you would never do that. And the patient had a sulfa antibiotic allergy. So let's unravel that a little bit. So, this is some of the thought process that we teach. This is from my oral antibiotic lecture. We do know that if someone has penicillin allergy, there is a 10% cross reaction, because the organic structures of these molecules look very close to each other, that if someone has a penicillin allergy in the first generation cephalosporin, not second, third, fourth, all the way down to 7, there's 7 generations. The first generation looks pretty close to penicillin, so they can have this 10% cross reaction. But I hear, time and time again, and, Joe and I sit through lectures and we have people come in, and they'll say, oh, if they're allergic to sulfa, they're allergic to everything else, right? They're allergic to the sulfonylureas. They're allergic to Celebrex. They're allergic to Diamox, HCTZ. Really not true. I'm going to try to unravel this for you in this next slide here. When someone has, now it's the antibiotic, this is what you have to get clear, right? You have to get clear that they are allergic to the like a polytrum, the sulfa part of that, the Bactrim, the sulfa part. It's not that they're allergic. So it's the antibiotic. Yes, I'm allergic to the antibiotic. It was a sulfa agent. They're not allergic to the S. If you look here and see this H2N in this little hexagon structure, that's an aryl amine group. The S is not the antigen or the allergic part. This is not what the body's reacting to. If you want to say anaphylaxis or hives or whatever, the histamine reaction, they're allergic to the aryl amine group that's out there. So that's why when someone comes in and they have a sulfur allergy, you want to find out what the sulfa is. If it's the antibiotic, then you really don't want to give anything that's a sulfa antibiotic, because it has this aryl amine group, right? But what happens if you go over and you want to give Diamox or Trusopt or Azopt? You just got to be careful, right? These structures are close enough. It has, this kind of pentagon and hexagon and CH3 and CH3, that they're close enough that you might want to give a test dose. It's not the S that they're allergic to, but these medications don't have that aryl amine group. And that's why if you had an antibiotic allergy and you've given Diamox, Azopt, Cosopt, Trusopt, or Neptazine, if you didn't want to use Diamox, you could, you got to wait with it safe. There's a low risk. How about if you go over to, atropine sulfate, and you have all these different neomycin sulfate, sulfites, polytrim, they kind of have these kind of sulfite type of endings to them. No risk, right? No risk. That's the key though. Remember, it has to be the antibiotic. If it's the antibiotic, this is all fair play. No worries. It's not the S. Here, the structures look similar. Go with caution, but most likely not going to have a problem. Now, if they are allergic to carbonic anhydrase inhibitors, they're going to be allergic to carbonic anhydrase inhibitors. If they're allergic to atropine, they're going to be allergic to atropine. If they're going to be allergic to a beta blocker, they're going to be allergic to the beta blocker, but it's not the S part that they're allergic to. So I just like to bring that up. All right. So toxic neuropathies. We started off with Andy Lee's kind of hate medications. This is going to be the Ethambutol that's out here. So you can see that there's quite a few medications here that can create a toxic optic neuropathy. And then over here, there's some different kind of things that are out there in the environment, solvents and fumes that can create a toxic optic neuropathy that's out. So ethambutol, it's still used to treat tuberculosis at one point. I'm not sure where we are, but there was an uptick a few years ago. But tuberculosis was on its uptick. This is not where I see this type of ethambutol toxicity. The 2 cases I had within the last 2 months, and I have a case here that I've been seeing for years because she's a glaucoma patient and a really cool patient to kind of learn from and see the visual fields. And I have to do her visual field and get it updated because it was 2022. I'm sure I have a 2023, if not a 2024 coming up here on a visual field. But I was looking at this earlier when I was putting the handout together, and I was mad at myself because I don't have the updated, but you'll see where I'm going with this whenever I show you. So ethambutol, this is a 81-year-old woman that comes in. She calls the office reporting decreased vision on the date is important because it was March 13th, 2019. She was warned of decreased vision with her medication. She's a glaucoma patient. I see her every 4 months, and she called the office and she really wasn't like strong about it. They just kind of moved her appointment up. And so when she called, I really didn't see her like on that day. And what I want to show you what her visual fields look like. So the key is I see it with this Mycobacterium avium. And Jessica Steen was just lecturing for us at one of the conferences. It was at Sarasota, and she was doing kind of a similar lecture. And she said, "Hey, Greg, did you ever see this ethambutol?" And I said, "Yeah, it's not really with the tuberculosis patient that comes in because maybe this is a short period that they're on this. This Mycobacterium avium is kind of what a low-grade staph, whatever, tuberculosis infection of the lungs. It's kind of chronic, so they put them on ethambutol, rifampin, and azithromycin. So the key is what I want to point out is if you have a patient comes in and they're like, "Oh yeah, I'm being treated for Mycobacterium avium," make sure that they are or they're not on ethambutol, because these have been my patients, 3 of them that have had this toxic neuropathy. She's a glaucoma patient. She was on latanoprost and Repressa, but she had a Cohook dual blade, so she's currently not on any drops, but we keep following her. These are her visual fields on 3/13/2019. Her visual acuity was 20/30, 2100 in this eye, in 2025. Glaucoma patient. I said to her, I said, name's Betty. Betty, what's going on? And so she, like, "Doc, my vision's down." And I'm like, she's at 20%. She's at 20% here and she's, a glaucoma patient. Like, she's not even showing up here on her pattern deviation. So I called the infectious disease doc up. Doc put her on this medication. They went over, they evaluated her, immediately stopped the medication. Good news is people ask, is this reversible? I didn't know. So she's like, I said, "Betty, I don't know if it's reversible or not, but we're going to stop the medication and we're going to follow you." So here we are. So you can see this is probably about 5 weeks later. Her visual acuity, if let's go back, was 20/30, 2100. She's at 20%. She's about minus 22 and minus 22 over here, 21.2. Remember, 32 is a blind eye. So she improved from 20% up to 37%. This eye a little bit more. She's up to 55%. And you can see that the defect is resolving. And so we have 20/25, 20/50, and together, those maculars are still working, and she gets those areas lined up, she can get to 20/20. So then we bring her back in July, and now she's back up to 91%, kind of showing that glaucomatous defect. And over here, showing that glaucomatous defect at 78%. So this is a case where the ethambutols, and at least the 3 cases that I have seen, they've all kind of reversed. This has been my biggest reversal. I've had some people with a little bit more damage that has stayed, but they've all improved. And maybe it was just because it was quick diagnosis and they weren't on this medication they were on it for a period, but not long after the neuropathy has occurred. So you can see this is May 9th. She is a glaucoma patient. You can see that we have some damage here to the inferior rim, a little bit more over here to the inferior rim. The nerves don't really look pale from this type of condition that had occurred. And then here she is in 2021. Again, here's the right eye. You can see down, remember, it was that inferior area is where the glaucoma is, and more over here in the left eye. And we can see that we've got this kind of nasal defect kind of matching, and we're back up to 92% and 85%, with her now pretty much just showing her glaucomatous optic neuropathy. Now, this is what I thought was kind of cool. So here she is. We'll look at the right eye first. You can see I've been seeing her since 2005. She's a glaucoma patient. And you can see kind of cruising along. This day she had a bad day doing the visual fields. Not sure, technician error or patient error, but we repeated it, and you can see that she did better. I maybe even repeated it 3 times that day. I just wasn't a believer, but maybe I tortured her and had her do it 3 times. But there's one, there's one, there's one. And you can see we're kind of cruising along. And then, I don't know, maybe that was around COVID times, and all of a sudden, that was 2019, it was pre-COVID, but you could see that there wasn't a visual field here, but then look at this drop. But then look how it came back. Boom, 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 boom over time. Same thing, kind of cruising along. And all of a sudden, maybe she was being treated for her, her avium, and just didn't come in. And maybe that was the gap. Maybe there's other health reasons, but maybe there should be another visual field here. But whenever she comes in, we do the visual field, and boom, she's way down. But it's really cool because you can watch her come up. Now, this is bad on the glaucoma progression analysis, because it's taken in these data points saying, hey, doc, she's going to be here in 5 years. So you got to take the GPA here, the glaucoma progression analysis, with a little bit of a grain of salt. But really cool case of ethambutol toxicity and reversal, and really cool because she's a glaucoma patient, and so I had all the previous visual fields to kind of share. Joe, any comments?
Yeah, you're very fortunate that you've seen that kind of reversal. There comes a time when you get you go across the point of no return, and unfortunately, it becomes irreversible. That kind of is the norm. The optic nerve is not a very forgiving structure.
Yeah,
Once it gets assaulted, it often doesn't come back. There are patients who I've seen with many neuropathies where I get the diagnosis and we get the treatment initiated, but there's no recovery. So that's why these are patients, if they're on the medicine, and I would wish the prescribers would send the patients out more often for evaluation. They do it for other medicines. They do it for hydroxychloroquine, Plaquenil. They don't do it enough for this. They need OCT, RNFL, and macula. They need threshold perimetry. They need a good acuity and color vision assessment. And they need it probably every month that they're going to be on the medicine. And if something goes astray, repeat everything. And if it still goes astray, now maybe we can get some stoppage and some recovery. But these are patients, if you know they're going to be on it for a year, well, you need to, schedule these examinations.
Yep, thank you. So the reason I unshared real quick and shared, because I forgot to turn the sound on. This is my patient. This is Betty. She captured a video. I don't really remember exactly what's in it, but we're going to play it. Joe, let me know if you can hear the sound.
Hey everyone, I'm sitting here with Betty Baker,
Yes.
and Betty 3 years ago, it's amazing, 3 years ago had a toxicity to ethambutol. And we just did a visual field today, which I'll show up on the slides here. But she's recovered nicely. But I just thought it would be kind of neat to go back and get as much as we can recall from Betty from 3 years ago. So Betty, can you remind me? I know you noticed your vision getting blurry, but you just kind of waited for your regular routine eye exam to come in that day. Now, was it that vision loss that you had? Was it sudden or gradual? That when you noticed that vision loss?
It was gradual.
You gradually lost it, right?
Yeah.
And you noticed some problems seeing, and you were just telling me about them. What were you having trouble seeing? You were telling me about reading, and what else?
Driving and reading, and I just couldn't see right. And
But you really weren't sure what was going
What
on.
was going on? But I thought it was that antibiotic.
That they
I
want.
read about it.
We read about it. We warned you about it. We told you it could happen, but you knew you were coming in for your regular glaucoma checkup. So we just kind of waited to then, and then we noticed it, right? So, but the biggest things were reading. It was gradual. You were having trouble driving. You really didn't give up driving, but you were really careful, right?
Yes.
You said you were maybe even a
Yes.
little scared to drive.
Yes.
So, and then we were able to call your infectious doctor, and we were able to stop the medication, and then the vision gradually came back, right?
Yes.
And now you feel pretty comfortable again.
Yes. Yes.
Yeah.
Yes.
Pretty cool.
It's fine now.
Yeah, you're fine now with at least the seeing part of it, right?
Yes.
Yeah.
Yeah.
Okay, kind of back to normal.
Yes.
Yeah, pretty amazing. So I'm glad you came in, and
Yes.
and thank you. And we're going to use this probably for teaching. You're okay with that, right?
Yeah. I was just happy I got to see you again.
Yep.
Better.
Perfect.
So just kind of, maybe it's my fault too. I have these patients come in and they're on ethambutol, kind of learn from every experience. Luckily she didn't lose vision. I kind of felt bad, like maybe not pressing upon her. Like I seen her every 4 months saying, hey, look, this medication caused this happen to your vision. And, she's like, oh, I'm just going to come in on my regular follow-up. And, she's driving with those visual fields, right? So a little bit of a, kind of a different way maybe I message it now. So we can all learn from our own patients that come in. So I say we're getting close, about 18 minutes here. We're pretty much right on time. I want to make sure I cover a couple of topics here. So, Dupixent, it's an injection for atopic dermatitis. It's for asthma. It's for chronic rhinosinusitis, and esophagitis. So we've got basically Dupixent here, and it has a big warning label. If you go to their website or you talk to the pharmacist, conjunctivitis and keratitis. And I'm going to bet that probably you've seen these and just maybe have missed them, or kind of blew it off as a dry eye or some type of consideration. But it's a well-known ocular warning, precaution, conjunctivitis, keratitis, right off their website. Consider, ophthalmological examination for your patients, develop the conjunctivitis, so on and so forth. This was my patient. She ended up with the condition that she has. She has alopecia. You can see she has, absolutely no eyelashes, which is really cool now. I've been following her, been using some the lash serums and following her over years, and she's just slowly continues to improve. But the camera's maybe not doing justice, but if you look here, she's all red, she's swollen, her eyes are injected. She's even got this kind of little ulceration of her skin. You can see red and dilated, swollen, the conjunctivitis. This here is the Dupixent. This is what it looks like, Dupixent. And this is a monoclonal antibody, right? So it's an injection. This is a biologic agent. You see it on TV advertised a lot. Here is the conjunctivitis. You can see how watery her eye is. Now, these patients love this medication, right? Their bodies improve, their atopic dermatitis has improved, their skin starts to feel better. She really didn't want to decrease or stop the medication. This is her on loteprednol, right? So this is just using a steroid. You can see here that the redness, even the upper eyelid swelling, the injection has improved. So this is what these patients look like. Here's just another picture before and after. I just have her kind of opening her eyes up. You can see the redness that occurs. Again, the ulceration, the amount of redness. And, I probably missed my first couple ones of these. And that's why I take pictures of my patients and put them in here and tell them we're going to use it for teaching and so on and so forth. But this is Dupixent, conjunctivitis that occurs. This is from the monoclonal antibody that they're using to treat it's usually like a dermatitis of some sort, like psoriatic or atopic type of dermatitis that's out there. Here's another case. A patient comes in and you can see the injection. This is a kind of a younger kid, probably 38, got, again, some type of dermatitis. And he's on the medication and he comes in and says, man, my eyes are just red and they're irritated, so on and so forth. Again, as Joe mentioned, thorough medical history, always review, don't always go by with the technician, make sure the technicians are constantly asking, are you on any supplements? Are you on any over-the-counter medications? Are you on any new medications? What are all the medications you're on? And so he was on Dupixent, and I said, look, it could be a lot of things, but I'm going to call it this a Dupixent, conjunctivitis. I flipped his upper lid here. You can see his upper lid is all injected. Again, he doesn't want to stop it. He's feeling great. His skin feels good, so on and so forth. Again, another Lotemax or loteprednol type of medication to use on this patient. Here's a video. I'll show a video of him. It won't be any sound, but you can see here when you examine him, it's bilateral. You can pull the lid down here. You could see that it's, follicles, papillae, injection, conjunctiva, on the bulbar part, palpebral. It's bilateral. It's usually a little bit asymmetric, just like most conditions. Glaucoma is asymmetric. Usually it's pretty equal, but usually worse in one eye than the other. I'm not sure here if I try to attempt to flip an eyelid on video. I think I'm going to do it. Yep. So I'm going to have him look down. Just flip his eyelid here, hopefully. Yep. And see that upper lid. You can see all the redness, all the injection across. So this is Dupixent. He doesn't really have a keratitis, but a conjunctivitis. Again, these patients don't want to come off. You tell them they're having an adverse reaction. They've been warned on it. It's the best that they've felt in a while. And they just don't want to, stop the medication that's out there. So just be aware of that biologic creating that. Sticking within the autoimmune agents, this one's kind of fading away, but just I've taken it out of this complication, but just recently, and I say recent, probably about 6 months ago, neurologist in town had a recently multiple sclerosis patient, and they put him on Gilenya, and they were looking for that fingolimod associated macular edema, and I was following him for that. For the patient. So I, unhid the slides and dropped it back in because it seems like it was out there, but there's some new biologic agents out there for multiple sclerosis. Basically, 52-year-old woman was placed on Gilenya is what it comes down to. The acuity drops. and it can create a macular edema is what can happen from this medication. So basically, prior to starting the medication, you want to get basically an OCT of the macula. You want to follow up in 3 to 6 months after the medication is started, and just be aware of the fingolimod associated macular edema. Stopping it will typically reverse the medication. It's kind of like Joe said a little bit earlier. It's kind of one of these idiosyncratic type of allergies that occur to the macula. Joe Shovelin one time was listening to this lecture, and he's after the lecture he said, "Hey, you mind if I send you a couple cases and put them in there?" And absolutely, Joe, it'd be my pleasure. Joe is a past president of the American Academy of Optometry. He's a Pennsylvania guy. Sometimes when Joe talks, I say, "Joe, I'm a pretty bright guy, but you just lost me there. Can bring it back down and bring it back to." But he sees a lot of cool things, and really smart guy, and glad to have him as a friend. And he sent me this fingolimod patient that occurred with the associated macular edema. And this is it after the medication was stopped. So pretty nice recovery there with this patient. The foveal pit. And really, when you look closely, you don't really see any structural damage that has occurred. So I'm gonna wrap up here the next 10 minutes. I'm going to talk, I'll probably skip through, just show the case of the Plaquenil toxicity. But this really isn't a complication. This is more I want to talk about like a public surface of Ella here. And what our role is. There is a complication from this treatment. That's why it fits into this lecture. However, it's the complication that where we get involved with the patient with ovarian cancer here. So there's a lot of slides in here. I included them into the slide deck. I'm going to kind of go through this. I don't want to turn it into an ovarian cancer type of, but we can be the limiting factor. So the key is we all have busy practices. I'm sure getting into Joe's practice might be a few weeks. Getting to my practice might be a few weeks to a month. But there are certain things that I talk to my front desk about. And when the oncologist calls your practice and says, "Will you see this patient that is on that we're going to put on Ella here? Please get them in that day." These are patients that have ovarian cancer, which are resistant to medication. This is kind of, in a sense, like almost a last-ditch effort. And basically, they need to be cleared by an ophthalmologist or optometrist. And I've done this lecture. I just did this lecture in New Orleans, and 2 of the docs were in there, and it was great because they were able to give, in a sense, validation. They raised their hand and said, "Hey, I had patients with this," and they said, really, the sad part is when the patients come in, they're all, they're all happy, and they're just trying to live life and maybe see their kids, but then you watch them decline over time. That was both of the comments that those doctors had. But, what's optometry's role here? Again, you can tell that it's a monoclonal antibody. They call this thing kind of a MERV. So it's an antibiotic, it's an antibody drug conjugate. And it's what it goes after, the FR binding antibody. It has this linker. I'm going to make this all make sense here in a picture. So basically, here is the medication. Here's the MERV medication, this monoclonal antibody. Here is the linker medication. This is what kills the ovarian cancer. So here's the monoclonal antibody, right? They usually are look like IgG, IgA, and it's attaching to the receptor of the ovarian cancer. Right here is the receptor. So it attaches, and then what happens is the ovarian cancer brings in this antibody, but what it has on it is the medication, which is now kind of like the time bomb that basically then, once it gets into the cell, is released, boom, and it kills the cancer cell. So what they're showing here are these cancer cells that are dying. But the process is that the antibody, this MERV antibody, this monoclonal antibody, which then has the ticking time bomb, which kills the cancer cell attached to it. You can see it's right here being phagocytized into the cancer cell. Once inside, the cancer cell starts to break it up, and then boom, the medication kills it. So that's what the patient is going for. And you can see right here for the platinum-resistant ovarian cancer that's out there, this PROC, platinum-resistant ovarian cancer. So, why is your patient here? Because they get these cornea deposits but it doesn't stop them from getting the medication. The oncologist will titrate the medication. So you just need kind of clearance to start, and then they just need follow-up. So Elahere is a therapy approved to treat certain patients with advanced ovarian cancer. There is truly a black box warning. Whenever you hear a black box warning, this is what it looks like on the pharmacist side. And so you basically, you can see severe ocular toxicities, visual impairment, keratopathy, dry eyes, photophobia that are out there. So it's this black box warning that can occur with this medication for ovarian cancer. And for those who want to kind of get in and read of, how and where it builds up in the epithelium, again, all these slides are in here for completeness. So due to the possibility of the ocular side effects, ophthalmic exams, preventative measures, lubricating drops, topical steroids, this is all kind of started with the oncologist. They just need an optometrist or an ophthalmologist to lay eyes on this. So we have a proactive management of the ocular events. The oncologist starts this, but then we kind of report back to the oncologist, and really they'll adjust the amount of Elahere for the patients that's out there. So the ophthalmic corticosteroids starting the day before Elahere infusion starts, and 3 days after the infusion, they get corticosteroids 6 times. They're on lubricant drops throughout the treatment or while the infusion is going on. There's you have to do a symptom assessment, visual acuity, slit lamp that's out there. So just be aware of these patients. Here's what the epithelial changes look like, or the keratitis. With the ovarian cancer, and this kind of, for lack of a better term, a last ditch effort, there's really haven't been any permanent vision loss with this. It's just that they kind of dose adjust it, and that's why they need our help with these patients that's out there. So monitoring the ocular adverse events, there's keratitis, keratopathy, there's a uveitis. Really, this is the key that I wanted to get to. You can scan this QR code right here if you want, and you can get this assessment form. This is what literally what the patient will bring, or the oncologist will send over. It's the ocular assessment form. I would encourage you to tear it off, print it, read over it, and then warn your staff, or, if you have an oncologist in town that you're friends with, that you think that you'll work with, call them and say you're familiar with this. If you ever get a patient, that you can certainly do a visual acuity, a keratitis, keratopathy check, and check the uveitis and report back. So this was more of, complication that occurs with the medication. I haven't seen a patient yet with this, but, I've had, like I said, when I do this lecture, or if I do my biologic lecture, I usually talk about it, and there's optometrists in the audience that usually raise their hand and want to contribute to the lecture. So for the sake of time, for 3 minutes, I'm going to hold off on this. Have you seen hydroxychloroquine? I think the opening slide kind of helped us with that. I'm going to go fast and show you some slides, and I'm going to show you a case, and then we're just going to land this right on time. The horse is out of the barn. Some of these slides are from Larry Alexander. The key is in Plaquenil toxicity, it's not a fovea disease. It's a pair-E foveal disease. That's important because you need to know where to look on the OCT. And the reason why I'm pausing, Joe, can you do me a favor? Can you look up the half-life of Plaquenil? I think it's like 45 to 50 days. And when I get there, I'll ask you, or you can contribute that to me. So look up the half-life of Plaquenil, if you would, for me.
Will
So
do.
you could see here fovea, but it's a perifoveal disease. And then we know, I think we all know that Plaquenil is for autoimmune rheumatoid arthritis. There's this whole gamut of way of treating it that's out there. We know that basically there's been all these renditions of, 2011, 2002, then 2011, you do an initial exam and then see them back in 5 years. I work right next door, less than a mile away, 7-doctor rheumatology practice. I see stuff all day long. All the rheumatological conditions, rheumatoid arthritis, lupus, mixed connective tissue disease, and the list goes on. I can tell you my personal opinion is, despite what all this stuff says, scan them and scan them every year, because we have obese people, we got thin people, and they're always on 200 milligrams twice a day, and individuality comes out. I have found Plaquenil toxicity 2 years of someone taking the medication. So again, this is the danger zone. They talk about this kind of flying saucer. It's a medication that builds up in the RPE and creates an outer retina toxicity, and it collapses. Okay. And so here's some advanced collapsing of this in the outer retina. So let me go through this case here real quick. This is a 71-year-old woman. You can see she's on Plaquenil twice a day. You can see nothing really showing up in these pictures. This is 2016. Nothing showing up on the fundus autofluorescence. I saw her, you can see this kind of area right here, -18. This is 3 years later. I saw her here and said she had Plaquenil toxicity. So I'm going to get down to where we're cutting through right here. As you can see right here, the RPE is building up the Plaquenil, and it's creating this outer in this perifoveal area. It's not a foveal disease. What I want to point out is I always see our lecturers talk about looking here, where I think it's important. I'd love to work, and I was working with OptiView, but then they got sold out. You look at this hill right here. Wouldn't this be fun? Live up north. Wouldn't it be fun to sled ride down this hill and fun to sled ride down this hill? See how these hills are here? Look at the flatness here. The hills are coming down. I told the patient she had Plaquenil toxicity here. She went and got another opinion. The ophthalmologist said, I know Greg, he's pretty, but I don't see anything going on. She comes back 3 years later. You can see the difference. Okay, that's the right eye. I'm going to show you the left eye. I called her Plaquenil toxicity right here in the other eye. She didn't come back, but I want to point out it was good for teaching, right? Look at this hill. This wouldn't be fun to sled ride. So I think a pretty cool following for these would be to follow the contour of this inner retina versus the outer retina and see if things collapse. You can see there was a 19 micron change in 3 years. So with that being said, Joe, I'm going to click through some slides. Joe Shovelin showed me a couple bad cases here. Again, he showed me this one and this one. You can see it's a perifovea type of disease. Don't look in the macula. It's a disease of the outer retina. And you can see here and here, they talk about this top hat appearance, but it's this perifovea, outer retina. And you can see this is not a really fun hills to go sled riding down. And these are the visual field defects on this patient with a, what type? It's a CETA-FAST. What type is it? Visual field. I don't see
It should be a 10.
Looks like a, yeah, it is a 10 right there. 10-2. So it's a 10-2. So, Joe, what's the half-life of this medication?
Well, the absorption half-life is 3 to 4 hours. The terminal half-life is 40 to 50 days.
Yeah. So my point of that is, so people will say, oh, we stopped the medication. Remember, it builds up in the melanin of the RPE. You stop this medication, it still hangs out for 45, 50 days. It's like driving a car, 50 miles an hour. You take the foot off the gas, you don't come to a stop, you'll eventually come to a stop. But that's what happens with this medication. The half-life of this medication is really long. So you can still see drift on these patients out to 6 months to a year from stopping this medication because of the very long half-life, that 40 to 50 days. So with that said, I am just going to see, Joe, are there any other questions? I'll launch this polling question here real quick. I'm just curious to see if people, found some help here.
There are a couple we didn't get to where we went a ways past. About the female patient, I think Dupixent using Lotemax, ointment or drops, and how long to use Lotemax for?
Yeah, Lotemax drops. I start them off QID. I tell them to use the lowest amount. They can self-titrate to make their eyes feel good. And they're usually on it to about 3 to 6 months. And then they seem to kind of burn out and adjust to this medication. Some are longer, some are not. Every allergy, in a sense, is a little bit different. But, I would say they're going to be on it at least 2 months out to a year. QID, they can self-taper, but I do bring them back for pressure checks.
That's it.
Okay. All right. Sounds like we're there. So with that said, before the CE stops, I do want to point out that if you want to go and take the survey, you can find it right here. I see the little red button on mine. There's a little red button there. That means the survey is active. With that said, we've answered all the questions. I want to thank everyone and Joe's participation here. This was Complications of Pharmaceutical. Every optometrist should know. This was a synchronous virtual course. I want to thank everyone for attending. Joe, any comments on the CE part here?
I think it was great, Greg. It was actually, I think a good way to describe it is a lot of fun. The way you presented it was engaging, and I thought time went flying by, and it was really a lot of fun to talk about. So thank you very much.
Yep, thank you. And thanks for your help and your comments and participation. That's what I think makes the fun part of it. So thanks. That will end the CE.